Hello, everyone. Welcome. We're happy to see you here today with us. Thank you for joining us for today's SBCMS webinar presentation, Preventing HIV through PrEP, Guidelines for Patients and Providers. I'm Allison Elsner, and I'm the CEO of the San Bernardino County Medical Society. Our partners today are from the San Bernardino County Department of Public Health and AIDS Education and Training Center Program, or AETC. I'm going to introduce our esteemed presenter right away, and then following her presentation, we will be glad to take your questions and answers. So as you're listening to our presenter, please go ahead and feel free to enter your questions into the chat feature on your Zoom dashboard, or if you'd like, you can click the raise your hand feature, and we may either go ahead and address the question during the presentation, and if we don't get to it, then we're going to plan to go through them all after the conclusion of the main presentation. And of course, if you're not speaking, we would appreciate it if you'd keep your sound on mute. So with that, we'd like to welcome Catherine Diamond, MD, M.P.H. Dr. Diamond is a clinical professor and medical director of the Infectious Diseases Clinic at University of California, Irvine. She's also a physician educator with the AIDS Education and Training Center for Orange County and the Inland Empire. Dr. Diamond, we'll turn it over to you.
Oh, okay. Thank you. All right. Now I'm going to try to share my screen. No, it's messed up again. Where is it? Oh, hang on. Let me turn that off. Let me throw this on. Sorry. I had it all set up before. Okay. Okay. All right. Sure. Ah, there we go. Beautiful. Okay. All right. Okay. All right, good. Everybody, can they see the presentation fine? Okay.
Yes.
So I'm Catherine Diamond, and I'm going to talk about HIV pre-exposure prophylaxis. And yes, just please put the questions in the chat, and we'll try to address them while we're going. Because I mean, you know what you need to know probably more than I do. So this is John Wooden, the basketball coach from UCLA, who of course said failure to prepare is preparing to fail. So the concept of pre-exposure prophylaxis is taking medication in people who are at risk for HIV, and that medication will prevent them from acquiring HIV. So this is kind of a graphic of the same thing. So you have an HIV negative person who engages in risky behavior for HIV, and they will either take a pill once a day or an injection every 2 months. And that will prevent them from becoming infected with HIV. So the pills that are approved for this by the FDA are Truvada, which is tenofovir diproxylfumarate emtricitabine, or Descovy, which is tenofovir alafenamide emtricitabine. There is also an injectable drug approved for this, which is called cabotegravir. So you might say, well, why are we talking about this today? And the reason is why the incidence of HIV in the United States is decreasing in general, but San Bernardino actually has had a 21% rise in HIV diagnoses between 2016 and 2018. But obviously the epidemic is still ongoing. So I'm kind of interested, which I realize in the Zoom format is not the greatest, if there are people in the audience who have had experience prescribing PrEP before. Here, now I'm gonna put my screen, trying to get my big screen on so I can see if anybody is answering yes or no. No? Yes?
No answers in the chat, Dr.
Okay, all right. So, okay.
Oh, somebody said yes.
Oh,
that they've had
okay.
experience.
Well, that's good. Okay. All right. So our objectives are to identify patients at risk of HIV as candidates for PrEP, to discuss use of antiviral agents as PrEP and to recognize acute HIV infection and to overcome barriers to PrEP. So this is again a picture of our Boy Scout, showing that if you failure to prepare is preparing to fail. What is the background here? So people may think that people at risk of HIV are predominantly men who have sex with men, but heterosexual women and injection drug users are also at risk of HIV. And PrEP is useful in all of these populations. So as I mentioned, there are 3 drugs that are approved for PrEP, and one is the Truvada, which was approved in 2012, and that's the tenofovir diproxyl fumarate emtricitabine. And then the second drug that was approved was the Descovy, which is tenofovir alafenamide emtricitabine, and that was approved in 2019. And then cabotegravir was approved just 1 year ago, and that's the injectable agent. And the only one that is available generically right now is the Truvada, the tenofovir diproxyl fumarate emtricitabine. So how does PrEP work? Well, both the tenofovir drugs, the Truvada and the Descovy, are both reverse transcriptase inhibitors, while cabotegravir is an integrase inhibitor. So these are drugs that interfere in steps of the HIV life cycle. I'm kind of taking a case-based approach here, which again, how well that will work with the Zoom, we'll see. So you have a previously healthy 19-year-old male. He presents with a urethral discharge, and he's diagnosed with gonorrhea. I don't know if anybody in the audience would like to kind of take just kind of a sample question of something that you might be able to ask this patient to assess his need for PrEP.
Feel free to just speak up, folks, or raise your hand or whatever.
Yes.
Zoom is so, I don't know, I'm kind of zoomed out. I was zoomed out 1 month into the pandemic, and now I'm really zoomed out. All right. I'll give you some examples of questions you might ask, and those would be, do you have sex with men or women? How many partners have you had over the past, for instance, I mean, you can pick a month, 3 months. Are you using condoms? Do you know if your partners have HIV or not? Are you having oral sex, anal sex? Have you been on PrEP before? Are you using injection drugs? Are you sharing equipment? So those are the kinds of questions. And to be honest, there are things where you can get a checklist for this, but really it's all just kind of common sense, which is why prescribing PrEP is not that difficult. So who is a candidate for PrEP? Well, so men who have sex with men are indeed the ones who have the highest lifetime risk of HIV diagnosis, but women and injection drug users can be at risk for HIV. One of the highest predictors of future HIV risk among men who have sex with men is a prior STD. So for instance, if you have a patient who has rectal gonorrhea or chlamydia, who is HIV negative, the likelihood, if they're a man who has sex with men, that he will have HIV within a year is 1 in 15. Similarly, with primary or secondary syphilis, if the patient is a man who has sex with men and is HIV negative, within 1 year, 1 in 18 of those men will have HIV. So whenever I don't know what your practice is like, but if you are seeing patients with STIs, sexually transmitted diseases and infections, basically that every time you diagnose one, that should like ring an alarm in your head. Hey, I should be offering this person PrEP, because this is a golden opportunity to prevent HIV. So these are the questions that I kind of already mentioned. but like I said, are fairly obvious. How many partners? Your partners have HIV. Are you using condoms? Who are you having sex with? What type of sex are you having? And are you using meth or other injection drugs? So let's say that this person is having sex with men. He's using intermittently with condoms. He's got multiple partners of unknown status, and he's never been on PrEP or post-exposure prophylaxis, which is PEP, in the past. So you decide that he's a candidate for PrEP, you want to start it. The first question that patients are usually going to ask is, how well does it work? And so like so many things, it depends on how well you take it. So here's a graphic of this. So there have been many studies that have shown PrEP to be effective, but this is one of the largest ones, called IPREX, with 2,500 people, half of whom got the Truvada and half of whom got the placebo. And they were followed over time. So the patients who were on the tenofovir disoproxil fumarate, emtricitabine, the Truvada, took it every day, or were assigned to take it every day, while the other patients, other research subjects, received a placebo. So over time, they found that the patients who were randomized to the tenofovir disoproxil fumarate emtricitabine arm had a 42% decreased risk of acquiring HIV. So if they took this medication every day, they were 42% less likely to get HIV. So you might say, well, that doesn't seem that good, right? 42%, I mean, okay. But if you look what they did by testing their blood specimens, they were able to estimate how many pills they missed a week. So they found that the patients who took their pills 7 days a week or 4 to 6 days a week had 100% protection against acquiring HIV. So the people who were taking less than 2 pills a week, much less protection, and then 2 to 3 pills somewhat in between. So the bottom line with this is, if the patient takes the medication, it is highly effective in preventing HIV. So given that evidence, your patient says, okay, you know what, I think I would like to take the PrEP because I want to avoid getting HIV infection. So, you know, your question might be, well, what tests do you do? How do you initiate the treatment? So the most important thing that you need to do is to make sure the person is HIV negative when you start the treatment, because the person who's on PrEP is going to think that they can have sex without a condom because they're not going to get HIV. So you don't want them to have HIV and then be having sex without a condom and spreading it. And then 2, obviously, I mean, it's important to know if you have HIV because you need to be on adequate treatment so you don't get sick. So the most important thing is to make sure that the person has a negative HIV test within 7 days of prescribing PrEP. And then you want to make sure the person is not seroconverting, because sometimes people will come and it will be right after a very risky encounter. Like that will kind of turn a light on their head, like, oh, geez, I better get on PrEP. I'm doing something really risky. So those people may actually be going from negative to positive. And sometimes they'll have symptoms that are like mono-like symptoms, like swollen glands, fever, sore throat. So you want to make sure the person is HIV negative and that they're not seroconverting. Dr.
Diamond?
Yes.
We had someone ask, can the negative HIV test be a rapid test?
So what I think it's better actually if you have a point of care rapid test that you can do. In that situation, I usually would want to get a blood test as well. So not just the rapid oral or the rapid finger stick, but I think you can go ahead and prescribe on the basis of the rapid test, but I would want to have the blood test sent to the lab also, because the blood test that you do, you know, from your arm, the standard 4th generation antigen antibody test, is generally more sensitive than the rapid test. So I think it's okay to start somebody on the basis of the rapid test, but I would draw the regular standard test at the same time and make sure you have good contact information for the patient and a follow-up appointment.
Great, we have another question. So if they think they can have sex without a condom because PrEP is keeping them safe against HIV, that is actually true, yes. And how do you encourage them to wear a condom anyway?
So, I mean, yes, if they are taking the PrEP every day, it's highly unlikely that they're going to get HIV. And I try to, I mean, obviously it's better if you have condoms available, like in your office, so that you can give them to people and you can, educate them at their visits to use condoms. But I try to be not very judgmental because I think then people won't come back. I mean, I think also you do sometimes have to watch out for things like sex addiction and stuff like that. And sometimes it can take more than one visit to bond with somebody, and to get them to kind of tell you what's really, really going on with them. So I don't have like a magic solution for this. Some places have like a health educator and you can refer them to the health educator. We don't have that here.
And Dr. Dorsey would like to add that PrEP does not protect against other STIs, including HPV.
That's completely true. Doesn't protect against syphilis, gonorrhea, chlamydia, herpes, HPV, or even like things like flu or COVID, right? That you could get from close contact, right? So these are the baseline tests you want to do. So as I said, HIV test is the most important one. So the standard test is an antigen antibody test. I usually will do the HIV PCR also because that will detect people who are seroconverting. The CDC has specific guidelines on who to do the PCR on, but I really actually kind of do it on everybody. If you're putting them on tenofovir drug, you need to get a creatinine clearance because the tenofovir disproxyl fumarate affects the creatinine. It can cause renal dysfunction. The injectable, the cabotegravir doesn't, and the newer version of the tenofovir alafenamide, the Descovy, is much less toxic to the kidneys. Both types of tenofovir are treat hepatitis B as well as HIV. So you always want to have hepatitis B serologies to begin with, so you know if that person has hepatitis B. And if they don't, then you can vaccinate them. And since HIV and hepatitis B are transmitted the same way, that's very important as well. Hepatitis C is sexually transmitted among men who have sex with men, and also among, in HIV drug users with meth. So you do want to check that. Hepatitis A, it can be sexually transmitted and is more common in IV drug users. So I usually will check that. The guidelines recommend checking lipid panel in persons who are on tenofovir or alafenamide because tenofovir disproxyl fumarate actually lowers cholesterol. I frankly think that's an extremely minor point. And, I mean, if you get to it eventually when you're taking care of the patient, I think it's fine. If you have a woman, you want to know if she's pregnant, the drugs are, the two tenofovir drugs are safe in pregnancy. With the cabotegravir injectable, it's really not clear right now. But you just want to know if your patient's pregnant or not always, right? And then STD, as we've said, the STDs are common in people with PrEP. So you want to be doing the syphilis and gonorrhea and chlamydia on the throat and the rectum and urine. So vaccines, I recommend hepatitis B if they're negative, hepatitis A, again, if they're a negative IgG, meningitis, the Menactra vaccine or Menveo is recommended for men who have sex with men every 5 years. HPV recommended up to age 26, optional up to age 45. And now we're also vaccinating against monkeypox as well. And anyone who is a man who has sex with men who is on PrEP should be vaccinated against monkeypox. And I know actually I should write M.P.H. They changed the name, I think like 3 days ago or something. So for my next one, I'll be calling it M.P.H. So once you get the person started, it's very easy. You do need to see them or at least talk to them on the phone every 3 months because they need an HIV test every 3 months. And then the STI check, the gonorrhea and chlamydia, throat, rectal, and urine, and syphilis every 3 months. Kidney test, the guidelines say basically every 6 to 12 months, depending on their baseline kidney function. I tend to just check it every single time. Every single time I do the same panel. I do a standard HIV test, HIV RNA, 3 site gonorrhea and chlamydia, the syphilis, and then the creatinine. And that way I don't kind of have to remember, has it been 3 months, 6 months, 12 months, because it does kind of just all blend together. I think if you were in a resource limited setting, maybe you might be, try to do the creatinine less frequently. Pregnancy for women, I do hepatitis C annually. Again, the guidelines recommend the lipid panel for people on tenofovir alafenamide. I don't think that's critical. The counseling about the condoms. And then, when you see them, you need to ask them like how many doses have you missed? Because obviously if they're not taking it, it's not going to work. And then do they want to continue the PrEP? And then every time you're just giving them 90 days to make it to their next appointment. Because you want them to get that HIV test every 3 months. So they don't think they're negative and then infect other people and not get the care they need. You're also looking for these symptoms of seroconversion, which are, as I said, mono-like syndrome, sore throat, rash, swollen glands, fever, which I know sounds like it could be anything, flu, COVID, syphilis, acute HIV, but that's the kind of thing that you're looking for. So usually I like to call them about a week after I give them the prescription to make sure they actually filled it. And then I'll see them at a month to see, are they having any side effects and how's the adherence? The main side effect that people will notice is about 10% of people will get nauseous, and then usually that goes away and you can tell them to take it with food or take it at night so they don't, they're sleeping when they're nauseous. And then you'll see them every 3 months. And like I said, it's the same visit every time. It's the startup is the hard part. And even that's not that hard, because if you miss something in the beginning, for instance, like, oh, I forgot to give them their monkeypox vaccine, you're going to see them every 3 months. You can, hopefully you'll get it done, over time. So this is the STI testing. So the throat and the rectal, they can do their own swabs themselves. You don't have to do it, or a nurse or doctor doesn't have to do it. They can swab their own throat and swab their own rectum, and that's equally effective to a provider doing it, and that saves a lot of time. If kidney injury occurs, if they're on the tenofovir diproxyl fumarate and they have an elevated creatinine, you can change them to the tenofovir alafenamide or to cabotegravir. And then most kidney injury is reversible, and bone injury, again, also typically reversible. And these type of things, bone injury will usually occur only with kind of more prolonged use. And the kidney injury tends to be more in the older patients who have hypertension, diabetes. Young, healthy people, usually these are not issues. So stopping the PrEP, obviously if someone seroconverts to HIV, that's a bad outcome, but that would be an indication to stop the PrEP. If you think they're seroconverting, then you want to treat them for HIV, obviously, and not give them PrEP. And then most common thing that happens is people say, you know what, I'm just not as at risk. I'm in a steady relationship and so forth. And so with that, you kind of have to say, well, it's hard tactfully to kind of say, well, like, how sure are you? And then tell them that they can come back, and they can resume PrEP if their risk, recurs, and that they, need to kind of think in advance. So usually you want to stop the PrEP 4 weeks after their last risky exposure if they want to stop it. Things that can go wrong. Well, pregnancy, not an issue. It's the tenofovir is safe in pregnancy. We kind of talked about if there's a kidney problem, you can switch them to tenofovir alafenamide or cabotegravir. Main problems are adherence, which you can do the standard adherence counseling that you would do for anybody, like if they had high blood pressure, take it, put it someplace where you're going to see it. attach it to something that you do every day, like brushing your teeth and so forth. And that's one of the hardest ones. And then the other hard one is when people don't come to their appointments and get their blood drawn, which I always don't really care if they come to their appointments that much, but I kind of really want them to get that HIV test every 3 months. So the appointments can be really simple, like a telemed, just to kind of go over the labs and set up the time for the next one. So what if they only have one partner and their partner is undetectable? So if the partner truly is undetectable, then they are not going to get HIV from that one partner. But remember that a lot of people will have one steady partner who's maybe undetectable, and then they'll have sex with other people as well. So you got to kind of be cautious with that, because relationships that may not be monogamous. Okay, so as we said before, PrEP doesn't prevent you from other STIs. Usually you need to take it for about 7 days before it's considered to be effective for anal sex, and about 21 days before it's considered effective for vaginal sex. Okay, so
before we move on to the case, we did have someone asking if you could please speak to assorted risks for trans men and masculine of center non-binary people.
Okay, so so basically the question is, if somebody is a trans man, how much at risk would they be? Or someone who's like more gender fluid, I think the question there is what drug would you use in that situation? And for sexual risk, you could use cabotegravir, or you could use tenofovir diproxyl fumarate. The tenofovir alafenamide, the Descovy, has really only been shown to be effective in men who have sex with men. So if you have a patient who is not a man who has sex with men, then you would have to use either tenofovir diproxyl fumarate or cabotegravir. The cabotegravir has only really been tested in men and women at sexual risk. So if it were an injection drug user, you probably would want to use tenofovir diproxyl fumarate. So in general, I mean, the way I kind of remember this is that the tenofovir diproxyl fumarate is the one that you can use for everybody. Doesn't matter what their risk is, man, woman, injection drug user, whatever their risk is, the tenofovir diproxyl fumarate, the Truvada, is kind of like your baseline drug. And then if they're not in that, if you're going to use the tenofovir alafenamide or the cabotegravir, you have to think, what is the person's risk factor? The tenofovir alafenamide, which is the Descovy, has only really been proven in men who have sex with men. The cabotegravir, any kind of sexual risk in men or women. Frankly, most people are, the cabotegravir, because of the injectable nature of it, I would say that it's less commonly used right now. Although I think that these injectable drugs are going to take off once longer acting drugs come out, and they are going to come out, I mean, I think in the relatively near future. Did that answer the question? Yeah.
They said in terms of side effects of drugs, yes. And then they would like to make a note that trans men and masculinity of center non-binary people are men who have sex with men in many cases. Trans women are not men. So they would just like to make a note of that. Another question we did have was, can the follow-up HIV test be a 4th generation rapid test?
Every time you see the person every 3 months, you should be getting the 4th generation rapid test. Is that, I'm sorry, wait. Every time you see the person, you should be getting a 4th generation test, which is a standard blood test for HIV, and an HIV RNA PCR, both. In the older guidelines, you only were doing the HIV antibody antigen, the 4th generation, and not the PCR. but in the new guidelines, they recommend checking the HIV RNA every single follow-up visit, and that's to detect these people who are seroconverting. Yeah. So the rapid tests that are like on your finger or oral, those are, well, there may be some that are antigen antibody, but in general, they're not as sensitive. So you're going to have to draw blood on these patients is the bottom line. You need venipuncture. Okay.
Thank you, and that's all for now.
All right, thank you. And sorry if I didn't understand anybody's questions correctly.
It's okay. Can we go back? Can we go back to the previous slide, please?
Oh, sure.
There was some misinformation.
Which one? Where?
Right here, right here. I believe it's this one.
Oh, okay. Oh, misinformation. I think you said misinformation. I was like, oh no, what did I? What misinformation?
Oh no, I'm sorry. No, missed.
Sorry. Okay. All right. I'm gonna keep. Are we good? Can I keep on going? Yeah. Okay.
Yes.
All right. So, all right. So then I'm just gonna briefly kind of talk about the 211, which is taking PrEP on demand. Okay. Okay. So this is a study called IPREGAY, which is on-demand PrEP in HIV in high-risk men and transgender women. So basically, this was a study done in France, mostly men who have sex with men who were at high risk for HIV. So what they did was they had the subjects take 2 doses of the tenofovir disoproxil fumarate, which is Truvada, 2 to 24 hours before sex, and then 1 dose 24 hours after and 1 dose 48 hours after. So that's why they call it the 211. So 2 pills, 2 to 24 hours before, and then 1 pill at 24 hours and 1 pill at 48 hours. So, and this is not an FDA approved indication, but it is in the CDC guidelines. So what they found was that the intermittent PrEP was effective in preventing HIV. So you can see in the graph that it was highly effective in preventing HIV. Although I would note that among these men, they had a median of 2.5 sex acts per week, so about 10 sex acts per month. And most of the subjects were taking 3 to 4 doses of the Truvada, the tenofovir disoproxil fumarate every week. So that's a median of 15 pills per month. So even though this was a study of on-demand PrEP, many of the participants were taking the medication, very frequently. Okay, so this is a graphic of the 211 again, so you can kind of see how it works. So this was tried to be replicated in the United States, and it wasn't as effective in the study that was done in the United States. And the reasons for that are not completely clear. Other thing to know is this is only for men who have sex with men, so not for injection drug users or heterosexual women, for instance. Also, you can't use it in people who have active hepatitis B because, as I mentioned, the tenofovir emtricitabine is a treatment for hepatitis B. So people would want to be on treatment all the time for that to avoid flares of hepatitis B. And then if people are having more frequent sex than once a week, it really can become very confusing about when they're supposed to be taking it and when they're not, and how when was the last time, and So I very rarely recommend the 211. The only time I will recommend it is if I have someone who kind of is in general not engaging in risky behavior and then goes on, vacations or something where they're at risk. And then when they come back, they resume their not risky lifestyle. So I mean, patients are very interested in this, but in general, I think it's too complicated to keep track of in your head. You know, and I mean, I think it's kind of similar to contraception when you think about it. I mean, basically, the birth control pill is safer, is more effective than a condom. So for preventing pregnancy. Okay, so here is case 2. We have a 23-year-old man. He presents 8 o'clock on Monday because he's interested in PrEP. He was a receptive partner with unprotected anal sex on 11 p.m. on Saturday. He overheard a friend saying his Saturday partner was HIV positive, and he parties with meth every weekend. So obviously this patient is at a very high risk. I mean, he had unprotected sex. It was anal sex. He's using meth. So with this patient, as I said, a lot of people will present for PrEP when they've done something pretty risky because that makes them think, oh, I should be on PrEP. But with someone like this who has such an extreme risk, I would recommend a post-exposure prophylaxis for him. So when do we use post-exposure prophylaxis? If you have somebody who has they call it a substantial usually a sexual risk for HIV, and they're presenting within 72 hours of the time that they had that risk. And so usually in that situation, what you would do is you would start them on tenofovir, disproxyl fumarate, emtricitabine with dolutegravir, which is Tivicay. So you're putting them on Truvada and Tivicay, which is an HIV treatment regimen, and you put them on that for 4 weeks. And then you obviously test them for HIV at baseline and at the end of the treatment. And if they've managed to avoid getting HIV during this extremely risky behavior, then after that, you stop the dolutegravir, you keep them on the Truvada, and then you keep them on the PrEP. So we call that PEP to PrEP. And then obviously that person would need to be seen every 3 months for the PrEP after. So I have a very low threshold for doing an HIV RNA. Like I said, I do one at baseline with everybody, and I do it every 3 months, which is what is in the guidelines. But if you read the guidelines, they do emphasize that especially if you're using cabotegravir, you want to be checking that HIV RNA at baseline and every 2 months. And especially in people who have been on PrEP or PEP recently, because those patients may be at higher risk for seroconversion or at high risk for false negative HIV testing. Anybody who has particularly high risk should be having an HIV RNA. And if they have symptoms of HIV seroconversion, they should be having an HIV RNA. And remember that if an HIV test is indeterminate HIV test often will be a sign that the person is seroconverting. So in some things, indeterminate means, you know, you think, oh, that means negative. But if you see an indeterminate HIV test in someone who has these kinds of risk factors, nine times out of 10, they are seroconverting. And those people have very high viral loads and are very infectious. So you want to, you know, find those people right away. So these are the symptoms of seroconversion, which are fever, muscle aches, rash, headache, sore throat, swollen glands, diarrhea. And then this is the graphic of the HIV testings. So your standard HIV test is going to be this 4th generation test. And the 4th generation test is a combination of the antigen and the antibody. So your body makes antibodies against HIV, and that can take a couple of weeks to start developing antibodies against the infection, while the P24 antigen is on the surface of the HIV virus, so that becomes positive much earlier. And then the HIV RNA becomes positive even earlier. So if you're testing somebody and you're doing an antigen antibody test, which is the standard 4th generation test, this test sometimes will be indeterminate, and then they'll have a positive HIV RNA because that becomes positive earlier. So this is the way that the test is run. You have this antigen antibody, antigen antibody combination test that can be positive or negative. If it's positive, then they do another immunoassay to determine if it's HIV-1 or HIV-2. So if the antibody test, the second test, this HIV-1 or HIV-2 is negative, and the first test is positive, they will call that an indeterminate test, and then will cascade to the HIV RNA, which some people call it a nucleic acid test, HIV RNA, viral load, they're all the same thing. So if you have a positive antigen antibody, negative immunoassay, positive HIV RNA, viral load, PCR, that's somebody who is seroconverting. Okay, so your patient has an indeterminate HIV test, and his HIV RNA is 1 million. And then in retrospect, he notices some fever and swollen glands. So unfortunately, this is an example of like a missed opportunity. This person is already seroconverted, and it's too late for them for PrEP. So just if you did by accident put this person on PrEP and you put them on tenofovir diproxyl fumarate emtricitabine, they would be at risk of developing resistance to the medication. So that's another reason why you want to avoid, I mean, there's many reasons why you want to avoid giving people PrEP who already have HIV. But another one of the reasons is that the virus will mutate and become resistant to that medication. So in this situation, usually what people will do if someone is seroconverting is you can give them multiple different regimens, which are, for instance, Truvada and dolutegravir, which is Tivicay. Or you could do tenofovir diproxyl fumarate emtricitabine with boosted darunavir, which would be, for instance, like Simtuza. But it really doesn't matter too much. You know, people often will use Biktarvy as well. Doesn't really matter what you give them as long as you give them one of these kind of standard regimens as soon as possible. Because you want to obviously get that HIV RNA down and have that person see an HIV specialist and have the partner tracing done to see, you know, have they infected anyone else and who infected them. So we call this rapid ART, which is, you know, treatment on diagnosis. So in the old days, and I kind of remember this because I'm old. You know, we had somebody who was newly diagnosed, we would draw their blood and tell them to come back in a month, you know. But now it's like if someone is turning positive, we literally have them leave with the HIV medication in their hands. And that's because basically it emphasizes how important the treatment is and decreases the viral load quicker, makes them more likely to come back because they need a refill. And prevents their health from deteriorating. So that's a definitely very critical change in practice. So what about future directions of PrEP? Just the tenofovir alafenamide was developed after the Truvada. And the main differences are it is safer on the bones and the kidneys, but it has not been tested adequately in women, basically, or those who have receptive vaginal sex. So I'm going to kind of skip over this. So this is a study called the Discover study, where they compared the Truvada versus the Descovy, and they found that they were equally effective. The incidence of HIV was the same in both groups. Okay, but here they do show that the tenofovir diproxyl fumarate is more, which is Truvada, is more likely to decrease bone density, and that there's more negative renal effects with the tenofovir diproxyl fumarate. What about cabotegravir? Now, cabotegravir has only been approved for a year, and at least in our neighborhood, the uptake has been fairly slow. But we do have a few people on it. And so basically, this was the study that showed the effectiveness of the cabotegravir, which is the injectable. And in this study, they compared tenofovir diproxyl fumarate, emtricitabine, Truvada versus cabotegravir, which in this study, they did use an oral lead-in period and then gave the injections every 2 months. And what they found was actually the cabotegravir was more effective than the tenofovir diproxyl fumarate, the Truvada, and that was probably mostly due to less adherence in the oral tenofovir diproxyl fumarate arm, because obviously it's kind of noticeable when you miss your appointment for your injection, but when you're taking medication at home, you could take it or not take it. So here is just a slide showing the greater effectiveness of the IM cabotegravir every 2 months. So you can see very highly statistically significantly more effective than the oral tenofovir diproxyl fumarate emtricitabine. It does cause pain on injection, but most people wanted to continue with the study. I have used a lot of this to actually treat HIV. There's a drug called Cabenuva, which is cabotegravir with rilpivirine, which is an HIV treatment, and I have used quite a bit of that. And yeah, there is pain with injection, but very few of my patients have actually wanted to go back to taking pills. So with this, you do want to do the HIV testing, RNA and antigen antibody every 2 months when they come in for their visits. So at their first visit, when they get the injection at 1 month, 2 months, and then every 2 months, and you want to do the STI testing every 4 months. And this drug has a very long half-life, like 6 months to a year. So it can be very difficult to diagnose a breakthrough infection because that can interfere with the HIV testing. So how this is going to kind of pan out in the long run, I think is not 100% clear. So this is a slide comparing all the different kinds of PrEP. So basically the tenofovir diproxyl fumarate, the tenofovir alafenamide, and the cabotegravir. So as I said, the tenofovir diproxyl fumarate, more toxic to kidney and bone, but actually causes weight loss and lowers your cholesterol for what it's worth, which is good, right? Both types of tenofovir will treat hepatitis B, while cabotegravir will not. And as I said, the tenofovir diproxyl fumarate is the one that's been proven in all populations who are at risk for HIV, while TAP has only been studied in men of sex with men and transgender. And the visits are every 3 months with the tenofovir, while every 2 months with the cabotegravir. And then obviously with the cabotegravir, you do have to come in for the injection. It is an intramuscular injection. While with the pills that you take at home, they can go to the lab and then you can do a follow-up on phone or Zoom. The price difference is very different among these drugs. The tenofovir diproxyl fumarate is only $30 a month, while the tenofovir alafenamide is $2,200 a month. And then the cabotegravir is about $1,500 for 2 months. So you sometimes will encounter insurance problems when you're trying to prescribe the tenofovir alafenamide, the Descovy. Not a lot of drug interactions with these, and they are the ones that you would think, like rifampin and seizure drugs. Other drugs that are in development are these long-acting products. So Gilead is the company that makes the tenofovir products, and they're developing long-acting tenofovir products. lenacapavir, which is a capsid inhibitor that can be given sub-Q twice a year, actually should be released very soon. So I think that's going to be a game changer. There's a drug called islatravir, which also has a long half-life, and that's a Merck drug. But the PrEP studies for that have been halted. But they are continuing to study develop it for the treatment of HIV. Also interesting are some vaginal rings with antiretrovirals, and there have been talks about vaginal rings combined with like PrEP and contraception. But those have not been offered for FDA approval in the United States. And then they are looking at some other approaches like broadly neutralizing antibodies. So hot topics. So in San Francisco now, they are starting to use doxycycline prophylaxis. So where you would take doxycycline every day along with your PrEP, and the doxycycline would prevent syphilis and chlamydia. So that's something that they may start doing more widely, although that is not in the CDC PrEP guidelines at this point. Issues with same-day PrEP, which I think is what people are getting at with these questions about rapid testing. And obviously, just like rapid start for HIV, a same-day PrEP is a good thing. And then issues about disparities. So people of color and women and youth having less access to PrEP. PrEP is safe to be used in adolescents and FDA approved for adolescents. These younger people may need more follow-up in terms of adherence. And then pharmacists.
I believe we have about 5 minutes.
Okay, I'm almost done. And I do want to take some questions, so I'm sorry. Just that pharmacists also are allowed to prescribe, initiate PrEP under California law. And so then these are some of the barriers to PrEP. This is very critical. I want to get this part in. This is Cynthia's very important part. So in terms of financial barriers to PrEP, I do want to tell you that the county does have assistance called PrEP app available, and they have PrEP navigators. So Cynthia, do you want to kind of make a pitch for your program here?
Yeah, of course. So 3 of our federally qualified health centers are certified enrollment sites for the PrEP assistance program. So you don't have to be a patient of our health center to access or make an appointment to get in to apply and enroll. On the slide, you'll see our appointment line. You can call and ask to speak to see an enroller for PrEP AP.
Yeah, so this might be the most important slide. Okay, so anyway, so basically, just with PrEP, there are financial programs available from the government to help patients pay for PrEP. And then Gilead, the company, also has programs. So really, there should never be a financial reason why people can't access PrEP, because it's overcomable. So these are the conclusions, that PrEP is underused, it's accessible and efficacious, but the key thing is make sure they're HIV negative at baseline and that you're checking that they don't have HIV periodically, while they're on treatment. And then adherence either to the appointments for their injection or to taking the pill every day is key. So I can try to take some questions now, and sorry if I kind of ran through the end. And then I think that that Cynthia was going to put a registration in the chat. So if you're feeling energetic, it would be helpful for you to fill out the registration so that we can kind of demonstrate to the government that there are people who are interested in PrEP and that we do need to do this education. Okay, any other questions?
I don't see any other questions in the chat right now, but I would definitely encourage people to go ahead ahead and raise your hand if you have something you want to bring up while we have Dr. Diamond with us.
Also, I would point out that Cynthia put her brochure in the chat, and that is kind of like it's a 2-pager, 8x11 2-pager of everything that I said in a 2-pager, and that has all the information that you would need.
We had a question. Someone's just curious, any research looking at CAB as PEP?
That is a really good question. But so could cabotegravir be used as PEP? And my guess would be no, because the half-life of that drug is so long. And because it has such a long half-life, it kind of interferes with your ability to have accurate HIV testing. Like, it will make your viral load kind of lower than it should be, or it could potentially even, there's some talk that maybe it can give you a false negative HIV test. So I don't, and also usually for PEP, you want to give at least 3 active drugs. So right now, there's not really like other long-acting drugs, I mean, other than rilpivirine. So yeah, I don't really see that happening, but I can definitely look that up. Yeah, it's kind of an interesting idea though. And then with the PrEP app,
I can answer that one.
Yeah, let me go back to that slide while you kind of explain that.
The registration for the PrEP app is, it's an assistance program for the cost of PrEP. So if the insurance doesn't cover it for someone who's uninsured, along with the other assistance provided by Gilead, they can also use or apply for the PrEP assistance program to help cover the cost of PrEP, similar to ADAP, which is the AIDS Drug Assistance Program.
Yeah. So yeah, this just I kind of glassed over this because we were short on time, but basically the tenofovir diproxyl fumarate emtricitabine, the Truvada, is pretty cheap. It's only $30 a month. Medi-Cal will cover it. If they don't have coverage with their insurance, there is a copay program from Gilead, and it's very easy to apply for. And then the PrEP app program is similar to ADAP, and so would also be something that people would be eligible for. And then the navigators that are available there would also, through the health department, if you're like, oh, this is all too confusing to me, I can't remember all this. I mean, I think if you just refer them, the navigator would be able to figure it out as well. Yeah.
And another question was, does it cover lab monitoring or just the drug?
I believe that the PrEP app will cover lab monitoring as well. It covers medical bills and the medication. Yeah.
Another question is, did you say you can register the patient for PrEP AP even if the patient is not seen through your clinic? And I can answer that one, Dr. Diamond. So yes, so the enrollment sites are open. They don't have to be a patient of that clinic. The enrollment sites are through the state. They get enrolled and certified as an enrollment site through the state. And so people outside of our health centers can make an appointment to apply there.
I should say that I'm not 100% sure the name of the program that pays for the medical bills is actually called PrEP app. It might have like a different name, but there is a program like that as well. Yeah. Anything else?
I think it looks like, unfortunately, we're nearing the bewitching hour, but if anyone else has any questions, now is your chance. Otherwise, we want to thank you so much, Dr. Diamond. That was just fantastic. So complete and thorough with your information, really useful for providers as well as all the community advocates listening in, and patients too. So thank you. And I see some nice remarks here in the comments about how much. Your remarks were appreciated. Also, what was Cynthia, maybe you can remind me, where's the evaluation you'd like people to fill out? You put a QR code in here, I think.
Yes, thank you. I attached an image of a QR code for an evaluation. If you guys could please use your phones, your phone cameras to scan that over, complete the evaluation. It will ask you to register, but once you do the registration, you can fill out the questionnaire.
That'd be wonderful. All right. Well, everyone, we want to thank you so much. Just really quickly, not to shift gears too much, but we do want to remind everyone that SBCMS is having a blood drive tomorrow at our SBCMS offices in Redlands. And that starts at, I think, 1:30, 1:45 and goes until about 6:30. So we certainly want to encourage people to come by. You can walk in if you aren't able to make an appointment. And we need to help alleviate this severe blood shortage in the county and in the Inland Empire. You can also register for your time slot at sbcms.org/events. So anyway, thank you again, Dr. Diamond. You're wonderful. And thanks for the partnership, Cynthia Turk with San Bernardino County Department of Public Health, and Dr. Diamond, thank you with AETC and UC Irvine. We want to wish everyone happy holidays, and we will be likely having a follow-up presentation after the beginning of the year. So please stay tuned and check our SBCMS Facebook page and website. Thank you so much. We'll see you all soon. Have a great holiday.
Thank you. Yeah, thank you for having me. This was actually, I think, the best Zoom audience I've ever had. So thank you.
Wow. Yeah, people were pretty engaged.
Yeah, lots of good questions, right? I was happy. Yeah.
Yeah, I think you bring that about, you make it really a comfortable situation for people to ask questions, Dr. Diamond. So we really appreciated having you and you setting up that tone. So thank you.
Well, yeah, thanks. And I'll come back sometime. I can do neonatal syphilis. All right.
Yeah, that'd be great. Actually, that's something that, our past president, Dr. Roloff, is involved in. So that'd be great.
All right. Well,
All right.
I'll see you soon. Thank you.
All right.
Thank you.